not reproducing anything. We have copied other countries enough. Let us develop our own. So please get ready. On your mark, let's go. So we are going to start clinical guidelines of practice from now. Thank you very much to Professor Bolaji. We are grateful to you. Okay, it's all right. So without wasting time, I want you to, we're going to have another father of anesthesia talk to us on another problem which has developed in our midst and is developing. So, and we need to face the truth. Substance use. His citation will be ready. But before then, I know you are all aware that we have rolled out a study in our midst to have a foundation of what exactly is this epidemiology, this incidence in our midst of substance use. So please, at some time in this conference, the QR code will be projected. Those of you who have it on your phone, please just take it and fill the form. We want that form to be filled, and let's have our own baseline study on what substance. Other countries have it, so please cooperate with us. Thank you very much. Please, who is reading the citation? Dr. Oluwatu? Dr. Dena? Okay, Dr. Dena, please, over to you.
State. He attended Federal Government College, Sokoto, for his secondary education, and then proceeded to Nigeria's premier university, the University of Ibadan, for his medical education. He graduated with his MBBS degree at the age of 21, making him one of Nigeria's youngest medical graduates at the time. Upon completion of his housemanship and mandatory National Youth Service Corps, he began his 11-year training in anesthesiology. This journey took him from the University of Benin Teaching Hospital to Germany, the United Kingdom, and finally to the United States. Professor Unomo is currently a full professor of anesthesiology and pain management at the University of Texas Southwestern Medical School and a senior consultant pediatric anesthetist at the Children's Health System of Texas in Dallas, in the United States of America. He is recognized as one of the world's leading pediatric anesthetists, especially in the management of children with complex head and neck abnormalities. He has also published numerous scientific papers in this field. Throughout his training and professional life, Professor Olomu has always given back to Nigeria, his home country. He has donated numerous equipment and supplies to Nigerian hospitals and doctors with the aim of improving the care and outcome for all Nigerians. Furthermore, he has taught, mentored, and sponsored numerous Nigerian doctors and medical students, both in Nigeria and the United States. These young students and doctors have gone on to achieve success and greatness in their own right. He is currently in Nigeria for this auspicious Nigerian Society of Anesthesia annual scientific conference in Gombe, where he will deliver a keynote address, and if you were there yesterday, teach modern anesthetic techniques at the airway workshop. He has also donated numerous equipment and supplies to Nigerian hospitals during this visit. He has also been nominated for the prestigious award for Physician of the Year in the Diasporan category. I want you to give a rousing NSA welcome to Professor Patrick Unomo.
You knew him, he wore a bow tie as well. So he just, and he went to Canada. People know him in Canada, my friends from Canada, Toronto, they know him very well. So we're happy to have had him, despite his very short life, but his legacy lives on. So with that said, I'm going to go into my lecture. This is a very touchy subject, but it needs to be discussed. We are used to, our job is to make people go to sleep, obviously in anesthesia, but also we wake them up. But today we are also have to wake up, okay? We have to wake up to the reality of what's going on so that we can move forward, okay? So my topic today is on the issue of substance use disorder among anesthesiologists. Next slide. So my goals today are to describe the history and the global landscape of substance use disorder. Oh, Daramola, I can hear you from here. I know your voice now. Okay, then outline the root causes and diagnosis and intervention for this problem and explore strategies for prevention. I'm going to move a little bit fast. I talk fast anyway, so can be on time. So Houston, we have a problem. We have a real problem, and the problem is us. We are the problem, so we need to take care of our problem ourselves. So we have to know about it. It's just a sampling of publications on chemical dependency, substance use disorder. In the literature, there's more. I just put a few for you to see the magnitude of the problem. I'm not going to go through all the studies. I'll go through maybe 2 or 3. Close my face. Okay. Thank you. Thank you, Dr. Kadakun. So I'm not going to go through all of this. I'll go through maybe 2 or 3 just in interest of time, but you can see the issue we're dealing with here. It's like every day there's something about this stuff. Narcotics are opioids, obviously, as we know them. Cannabis was available even way back in the 3500 BC. It was used for medicine as a medicinal agent, used in ceremonies and also for other things. But also they loved it to use it for recreational purposes. So they were using this stuff to get high from back then. Alcohol was also used. Of course, we know that various tribes in America, in Latin America, we know about Bolivia, where they use coca leaves to, get high. Also in the Egyptians also use all kinds of agents, alcohol for medicinal and, recreational purposes as well. In Africa, we also have this, we use cannabis. There's something called cat. We use that something in East Africa, Central Africa. They use that as a stimulant. Cannabis was known to people in Sub-Saharan Africa, which is us. Palm wine, of course, is derived from fermented palm sap, and it's still used to this day as an alcoholic beverage. And I like palm wine actually. Just not in excess, okay? Okay, all right. Of course, in India, people have used all kinds of agents for stimulation of the mental state. Things like soam, and also they use bang, something's called bang, B-H-A-N-G. Bang is nothing but edible cannabis, and they use, so this is, they have this celebration in India. I know about India because my wife is Indian, so I've been to India several times and I know so thank you. Yeah. So I'm not trying to call them a bad name, but I'm just trying to explain that I know this ceremony. It's called Holi. It's a celebration of colors, so they have this powder, colored powder that they stir themselves. But at this point, everybody you see here is already high on cannabis right here. I'm telling you, I've been to this before. I didn't inhale. I was there, but I did not inhale. So, but all these guys, everybody, the guys and the girls, are already high on this band, which is pretty much edible cannabis. Okay. And also, if you go back to historic times, those of you who believe in Greek mythology, you would have heard the story of Odysseus, who was, this guy is traveling with his people. And they met this woman over here, her name is Circe. Left pointer, so on the left, the one with it. So you can see she's holding a cup up on her right hand. She has a cup up, and that's some kind of potion of some medicine that she used to give. So she was basically a witch. She was what you call a witch, a sorceress. So she will give it to men, and they will either be bewitched or they will change to swine or something. So again, there was some stuff. They think it's something like maybe today's mescaline, which is a stimulant. In the middle is Demeter. Demeter was she was famous in the Eleusinian mysteries. So basically, she had a cult, and people would put her cult and worship her. Now, what's she holding in her hand? On her left hand, she's holding a poppy plant on her left hand, which is opium, right? And on the right hand, she has a cup on her right hand, you can see, which is ergot, the nothing is ergot alkaloid, from which you derive stimulants as well. So again, on the right is the statue, the Minoan poppy goddess. You can see the poppy heads on her top, 3 poppy heads right there. And this dates back to 1300 BC. So the point of this is it just tells you that drug use has been around for a very long time. So it's not a new thing. Even more recently, we know people use ether and nitrous oxide. They inhale it. They have nitrous oxide and ether frolics in America, maybe in Europe as well. In fact, if you look in Ireland, to your right, you see those men over there on the right, just getting high and being so happy. They are drinking ether, not inhaling. They were drinking ether, and they're getting high from ether. In fact, they said one guy drank the ether, and then he went to light tobacco or something, and then his mouth caught fire. Because ether is very flammable, as you know. So, and in fact, they claim that the Catholic Church, which of course was the dominant religious group in England, in Ireland, I can say that I'm Catholic, so they encourage people to drink ether instead of drinking alcohol, because drinking alcohol was a sin, so they say drink ether. So that's why you see those men being happy drinking ether. So again, it just tells you that it's been going on for a while. So it's a global problem, so let's get into this problem now, what we're dealing with right now. So, excuse me. So I come in here, and you all have seen this, right? Have you all seen this all over this hotel? It's everywhere. Anytime you turn, you see this sign. So, again, there's a problem, right? Not only the doctors or physicians, but also in the public. There's abuse of different substances, as you can see. Senior leaders, pay attention, and then begin to open your eyes to these guys. So again, just kind of a few hints again. There's more. Also, some of them they wear an inner sweater that is very long. They don't wear like a tank that I'm wearing. They wear a sweater inside the scrubs, so you can see the middle marks, or even some of them have an IV in place, right? So you can so this one. They have family problems. Of course, they have marital issues, sexual issues. They have drinking convictions. The children are not happy. In fact, the house is almost broken because of drugs. This is a damaging problem that will destroy the family. Right, so I'm going to go through one or two studies to, kind of highlight what's going on, and then we'll wrap up in terms of time. So this was one study that came out. They sent a survey to 103 programs in the U.S. 103 returned, which is a response rate of 93%. So of these responses, 81 were residents, and then 55 were faculty. So they found an incidence of SUD, substance abuse, in 1.6% of residents and 1% of faculty. So it does happen, but after they seen that residents seem to have a higher rate of it, but faculty also have it. So that study is a very interesting study. So in this case, they looked at a retrospective study of residents from 1975 to 2009. So this led to 44,000 residents being analyzed over this, many years, like 33 years. So they wanted to look at outcome measures of incidence of substance use disorder and cases and rate of relapse. The relapse means that you abstain from drugs, you are clean, and then you fall back again. So it happens. So they found, it's very important, they found that 384 residents had SUD during their training. Of these, 20 of them died during training. All right? So that's like 7.3% died during training from drug abuse. There was a 30-year follow-up, 30 years follow-up from when they finished residency, and they found that there was a very high rate of relapse, about 4 in 10 relapse. So problem. So now the next study, this next study is the same study pretty much that I just showed you, done in a different way. So what they did in this case was to find out the risk factors. So to find out risk factors, they have a control group, right? So they looked for the same 384 residents who had SUD from that previous study, it's the same authors. They now did a 2-to-1 matching, of people who did not have SUD, right? So it's kind of trying to do a prospective study without actually doing a prospective study. So you will look for controls who are similar to the patients that have the problem. So they did a 2-to-1 match, so leading to 768 normal people who didn't have drug abuse. And then to see, what's the risk of these people who have SUD. So they also looked at whether these doctors were American medical graduates or foreign medical graduates like myself. In fact, this study, as you can imagine, was done between 1996 and 2002. So I was part of this study myself because I joined the US presidency in 95. So my name was up in this study without me knowing about it, because that was when I was there. So what did they find? This is what they found. So you can see in the red scale, so between 1996 and 2002, you can see that the number of foreign graduates was going up. Why? This was the time when there was a lot of doctors in anesthesia in America. There were so many doctors in America. The pay was so bad. When you get done, they offer you the pay of a nurse anesthetist. There were so many programs in America that had so many doctors, programs that had like 10 per class. So the pay was bad. People were doing anesthesia in America, which is why I got in in 1995, because the Americans want to do it. So but what does that lead to? So we got in foreign graduates in red, went very high up. And then what happened to the rate of drug abuse? In the blue, it came down. You see that? Up in foreign grads, down in rate of drug abuse. And then after that, what happened? Foreign grads still became better from anesthesia. American boys came back. Foreign grads reduced. And what happened? Rate of drug abuse went up again. So I guess you can see the issue. So being a foreign grad makes you less likely to be a drug abuser, whereas Americans apparently seems like that's all of them. Next slide. So when they looked at the controls who had no drug use versus the people that had drug use, what did they find? They found that if you had a substance disorder, you are 8 times more likely to die after residency, 15 times less likely to complete residency, 10 times less likely to become post-certified, and 7 times more likely to have a problem with your medical license. You can get suspended or you can get removed from the medical register. And then you're going to higher rates of dying, 20 of them died, whereas 0 of the control died. Now if you look at the 30-year period, 54 residents with drugs died, because of abuse died, 14%, whereas 10 of the controls, 1.3% died. So there are people who are dying. It's not a joke, it's a problem. People are dying and getting themselves killed from this problem. All right, so this is the last thing I'll talk about, and then we'll wrap up. Look at propofol. I talked to you so far on narcotics and cannabis and marijuana and alcohol. Let's talk about propofol. Can we get a little silence and quiet, please? So much background noise. Thank you. Thank you for your attention. So propofol addiction is becoming a problem now. So this is a study of 22 patients who were treated for propofol addiction. So you can see that since the 90s, it's going up from this graph. The rate of propofol abuse is going up. It's going up. So I don't know, do you guys control propofol in Nigeria? Is it like another lock and key, you have to send for it? No. Same in America. It's there. It's there. You know, I've known 2 guys who killed themselves propofol in the last 3 years. Anesthesiologists. So, but it's still not controlled. It's still there. You don't do that, just take it home or whatever. It's there. I just don't understand, but anyhow. So again, I'm just showing you. So how do they present? How do they present? You should know that because it may be coming here in Nigeria. Maybe here already, we don't know, but in America it's there. How do they present? They present in a traumatic motor vehicle accident. They take propofol, but some of them pull off the highway or whatever on their way home, and then they shoot up themselves. And then, there you go. Stop taking it again. What do you think is going to happen? You're going to get to a also been having a car wreck, 3 car wrecks in the last 3 months. Be very worried. And then they also have facial injuries from the car wreck, the shattered glass on their face, or the fall. Be worried. And they work in the OR, or the nurse, anesthetist, or physician, anesthetist. Be very worried. Okay. Also, they have the business of depression and trauma. And the main reason for this problem, the reason for propofol use is to get sleep. Are we okay? They want to sleep. They feel like sleeping. Yeah. They want to sleep, so they can't sleep. If you have depression, you have to sleep. Anxiety, problem with sleep, so they want to sleep. So, so what happens? Take propofol, you experience a few moments of euphoria, which you get a high, right? And then you get into a brief sleep, right? And then you wake up again, and you want to do it again because you are craving now for the drug, you want to have it again. So this continues and continues, and you keep using higher and higher doses to achieve the effect. Now, look at those pictures I showed you right there. Count the vials. There are 20 vials of propofol. How many milligrams in one vial? 200 times 20. How much is that? 4,000. 4 grams. One of these patients used 4 grams in one day. If you don't know what 4 grams looks like, that's what it looks like. Right there. 20 vials of just slowly, injecting himself, injects a little bit, like that, inject again. 100 times of injection, 100 times of injections, and he gave himself 4 grams of propofol in one day. I mean, just put an infusion of it. This is almost like getting an infusion of propofol, right? Just put an IV and hook it up to a pump. That's what he gave himself, 4 grams of propofol. So luckily he showed up, or they found him somewhere, maybe in a car wreck, and he got rescued. 4 grams of propofol in one day. So it's not a joke, it's happening. Okay, so then they get busted. Now I gotta say busted, that is it. They get caught. So when you catch them, then, okay. All right, no more time for that. So now they get busted, they get caught, intervention. So there are 3 groups of people when you catch them. So first group, they are fearful and they are ashamed. That, oh my God, I've been exposed, I'm losing my job, my career is over, my family. The next group is relief and thankful. They're thankful that they've been busted and now they're going to get treatment, which they couldn't get themselves. You can't get yourself treatment, you're not in the state to get yourself, you are helpless. So they said, thank God I've been busted, now we're going to get treatment. And then the third group is that they're angry and denial. They start lying, like, no, I didn't do anything wrong, and, they're defensive. So this is the algorithm in America, at least, what we do. So those first two are going to want treatment. They're going to be like, okay, help me. I got a problem, I don't know, I'm busted. So no problem with those, they go for treatment. So they go to employee health, they sort them out and they go for treatment. This guy over here is the problem. So he's angry, he's denying. So you send him to the occupational health, and then tell him that, okay, you're denying, we're going to test you. So go to employee health, go get a test. It's like, okay, go get a test. If he says no, if he says yes, then that's a good thing. He gets a test, it's positive treatment. It's pretty straightforward, right? If he refuses the test, then you're going to suspend his privileges in the hospital, right? So you put his privileges, that means that he cannot work in the hospital anymore, and then you're going to report him to the state board. So basically, MDCN, is that what we call it here? Yeah, so state board, you report him there, say, this guy's got a problem, I'm taking drugs. And then at that point, he has a choice to go to treatment and save himself. If he still refuses to go to treatment, then you're going to pull his license. You pull his state license, because this guy is clearly a danger to himself and to the society and the patients. So you suspend him. And then when you suspend him, then he has a choice. Should I be suspended and say, I'm not working, or go get treatment? So at that point, he's going to go get treatment. So it's pretty straightforward, There's no, yeah. All right. Next slide. No moving, maybe here. Next slide. Oh, now. So, if you suspect a colleague to have this problem, what do? So, we must also be our brother's keeper and our sister's keeper. You have to report, okay? Report to your clinical director, report to your head of department, report to anybody who's senior to you and let them know. Don't try to confront the person directly. Just report the case to your upper level and then they will figure out how to deal with the issue. And then when the head of department discusses with them, you should have a record of the discussion, keep records of it, keep a minute, have a witness in the room when you talk with them. So they won't say you didn't tell them about this issue or deny anything. If you are not medical staff, like a nurse or an anesthetic, you think a doctor or anybody who's influenced, talk to your nurse manager or your upper level, and then that will go to the health department, and then they will do it. So it's our duty to report this. It's not a joke. Don't cover for your colleague because we're not dying. So final thoughts for me. So HIV is a disease, it's not a crime. In America, some others are very crazy. Well, they want to just make a point. So the doctor has been caught. He's sick, obviously, he's going to get treatment. For the doctors, the hospital will go after them and try to sue them for stealing their drugs. So for theft, they sue the doctor for theft. Because you use 4 grams of propofol. That means you stole 25 hours of propofol, right? The hospital owns the medicine, so they're going to sue the doctor for stealing the medicine. But of course, that's stupid. Some crazy just do that just to make a point. Usually it doesn't go anywhere. The doctor is sick, right? He needs help, not trying to crime. Okay? So again, don't wait until there's evidence beyond a reasonable doubt to seek help. It will be too late. Again, as I said, all of us, all grace of doctors can have it, but not just trainees. And we have a duty to support a colleague who is sick. Don't make him feel ashamed. Don't make him feel bad. He needs our help and support. Okay? Thank you. Next slide. Oh. Yeah, next slide. So what are the next steps? We have the study, the terrain study. Madam President mentioned that just now. That was going to do a survey to kind of address the issue. We're not going to shame anybody or out anybody. We want to know the landscape of a problem that may be in our midst that we're not aware of. So this terrain study, as you can describe, you can see here, mentioned a survey of substance use disorder in Nigerian doctors. It's only for the it's for Nigerian doctors as a whole. Let's learn from it. Let's see where are we? Is it problem everywhere in the world? What is our problem? Do we have a problem in Nigeria? Maybe we don't have a problem. Maybe everybody's fine, but maybe not. We'll need to find out. Professor Tony Onyeka is the PI for that study. She's fantastic. She's done a fantastic job to put that study together. So please let's support her with a very good response rate so that we can learn information that will be used by leadership to address the problem that we need. So please support Tony for that. She's amazing. Again, not America the whole time. The UK, there's a problem too. The UK is everywhere. Drug and alcohol abuse among visitors, guidance for identification management. So this is a committee that we'll put together to address this issue. We have something, the ASA also has a committee that deals with wellness and substance use disorder. So every country or society has something. So let's be thinking about that. So what's my charge to you in my final thoughts for this address? Please participate in the terrain study so we can get a good response rate, which will make it very valid. Also, I think that Madam President, with all due honor and respect, the NSA should work with the NMA to come up with a committee to address the issue, or to at least look at the issue of physician wellness, drug abuse, anxiety, burnout, all these things are happening around the world. It's happening in America, it's happening here. So I think we should have a committee, a working group, Madam President, for this, with the NMA. Okay, so let's, emphasize that and do more, to learn more and support, and come up with, guidelines. Dr. Balaji talked about guidelines. We should come up with guidelines of how we support our physicians, our colleagues who may be having an issue and need our help. So that's the same thing. We have to own the problem. It's our problem. We need to own it and deal with it. Let's serve ourselves, not serve for us. So we're going to say, Happy DM, see you today. Thank you.
very much, Professor Patrick Olomo. Yes, he deserves a standing ovation. Please, let's do that and appreciate him for bringing this thing right before us. No more hiding place. He has told us. Now we want to do a number of things quickly. Time is not still in our hands, and therefore you can see why we are doing some things, unconventionally. I'm so sorry about that. This from home. Please fill the forms online. Can we project the QR code, please? QR code of the terrain study. So we need to fill the form online. Then we need to tell all our colleagues around us in the states, not just anesthetists, all physicians. Please let us encourage them to fill this form. It's our own deal for Nigeria, please. Thank you, everyone. Do we have dealing with this subject excellently, and it has met everybody's expectation. I'll call Dr. Jaro to do the presentation.
Sir, Doctor, this award is presented to Dr. Mohammed Bello Raji, our keynote speaker. On behalf of NSA, I wish to present this this award as a token of our appreciation for the beautiful presentation, for the time you have taken to educate us this morning. On behalf of this association, we present this pledge to you to appreciate it. Thank you.
Very much. Now I'll call on Professor Patrick Olomo for this token. We cannot pay you enough for all that you do for Nigeria, and you've been doing this thing for Nigeria for more than a decade now. So please accept this token of appreciation, Professor Olomo, and I'll call no one but my able General Secretary, Associate Professor Saidu Yakubu, to do the presentation.
Thank you, sir. Thank you.
Professor Patrick N. Olomo, sir, on behalf of the Nigerian Society of Anesthetists, it is my pleasure to present you with this award of honor for being the best friend of anesthetists in Nigeria, for that sacrifice you've made to come to GOMBE State, and for the great lecture you delivered today on substance use disorder, and for encouraging the Nigerian Society of Anesthetists to work with the Nigerian Medical Association to come up with a study on the situation of substance use disorder in Nigeria. Thank you very much, sir.
Dancing to my tunes. Is it too much? It's not too much.
You are tempting us, so you want us to start dancing now. By the way, Professor Olomo is actually the originator of this study. Can we give you a hand of applause? Okay, because he called me around, I think, December or January and said he has a burden. He has a burden. What can we do? Let's check out what's happening in Nigeria. And now the vision has been actualized. Thank you. In fact, he wanted that study to be out and presented in its findings in this conference, but it's well. All things work for good. So, without wasting time, I'd like to call on our able elder teacher, my own very senior brother, Professor Bolaji, told us that, look, it is time for clinical practice guidance. And he also bared his mind to me and said, President, it's time. So please get ready. We'll be calling you to committees to work with him, and we must deliver. So I want to invite Dr. my own able treasurer. More than able treasurer, I can afford to sleep, I have no fear. Dr. Oluwaju. And guess what? She's actually my baby in anesthesia. Very trainable, teachable, and now she's doing wonderful work in the world of anesthesia. So Dr. Oluwadu, please honor my big brother and medical elder.
This is indeed an emotional time for me. It's a case of the young shall grow. Professor Bolaji was my teacher in the University of Lorraine. I entered into anesthesia, and I met him. He has been a good guide, he has been a good support. He came into SAM to support me. I didn't believe it was so emotional. Thank you, sir. On behalf of NSA and the boards of trustees, we want to thank you for doing us the honor, for taking us in this wonderful Professor Kwame lecture. It was pretty enlightening, especially when you brought out your own handbook. I was like, that is brought for you. It keeps things. And it didn't look torn. It's intact. And we will take up the challenge to create guidelines, and we will make sure that this lecture you have given us will bring out results. And the next lecture will be the guidelines that came out as a result of this lecture. Thank you very much. Thank you.
Okay, DJ, it's not time for that yet. Please, hold on. So thank you to everyone. Now we want to start with our big time supporters. And I hand over to the MCs.
Thank you so much, Madam President. At this point, we'll call on Draga for their presentation. Our industry partners, Draga, are they here? Draga. Okay.
Up till today, with the advancement we have with the Atlan anesthesia machines, the pressures and disease that people have come to know, we are a technology-driven company that people have continued to rely on for these technologies in those critical moments for themselves and also for their patients. And so whether it's anesthesia machines, ventilators, our anesthesia machines are being used at least in a third of every theater every day. The workplace infrastructure technology that we also have for gas management and for gas supply, both in generation and also at the terminal ends where you use them, have been technologies that people have continued to rely upon and depend on for the quality and the durability of this technology. And of course, everyone seems to trigger for quality and for durability. And these are because that is what we live to provide the technology that you need for life. We share those goals with you in improving clinical outcomes, in ensuring that when you buy equipment from us, these solutions are able to serve you for a prolonged period of time, so that you are investing in expanding, not in replacing those equipment. And interestingly, I think with us re-entering the market, we have seen anesthesia devices or ventilators that have been installed more than 20 years ago, and just with basic maintenance are being revived and being used by their customers. So these are things that we pride ourselves in to provide those overall total cost of ownership that are cost effective to you. And in ensuring that technologies that are offered to you are easy to use, making your life easy, so that that way you can provide the best patient satisfaction that you're looking for. Now at Vega, we have this vision to ensure that for every preventable death in the acute care space, we want to be able to provide the opportunity for that to be prevented and to give you the best chance to be able to meet that objective or that outcome that you're looking for. So both in terms of the products and also for the services that we offer, we are designing and we are offering these products and solutions and services to ensure that your life is made easier and your work is facilitated. And around here we have 4 key pillars that we walk through around the equipment or the technologies themselves. How are they able to meet the varying needs that you might have? The different challenges that you have with different types of patients and the kind of diseases that you continue to diagnose and see now, which brings newer set of patients getting older, being sicker, even being smaller, into the operating room. How are we able to help you manage those patients easily? So in terms of the technologies themselves, important to give you the solutions that are able to go the breadth and span of the different types of patients that you see in the operating room, while connecting them so that you are able to have those data wherever you need them. And of course, workplace infrastructure increasingly is being shown to impact the satisfaction of people who work in the critical care space, in the acute care environment, because managing workflow makes life a lot easier. And we'll see quickly just how these are managed from a Drager perspective. Within the whole hospital portfolio, we cover from anesthesia devices to ventilators to incubators, patient monitors, accessories, because we know accessories also can frustrate the life of a clinician. You might have the best devices, if you don't have the right accessories to be able to use those devices, then that hampers or limits how effective you are able to use those technologies. And then the after-sales services. Providing equipment that will require as low maintenance requirement as possible, while when required, then we should have the right structure to be able to support you when you need that. So within the perioperative care environment, we have a range of different technologies which are highlighted and well known to you that we offer, from the anesthesia device to the monitoring devices to gas supply units and other technologies to be able to provide you with the best of workplace to be able to deliver in those critical moments. And with the workplace infrastructure, we have the possibility to be able to create different types of ORs for you to be able to work with, while for the specific device and technologies that we have, we are continuing to ensure that the anesthesia machines that you get and other equipment and technologies that deliver ventilation are able to continue to protect the lung of the patient while delivering the anesthesia to that patient. While at the same time, you have a lot of information that enables you to safely deliver, whether it's low flow anesthesia or deliver whatever technology or technique that you want to be able to use to improve the outcome in the patient, improve oxygenation, recruit the lungs, and other clinical tools that are required. And we are offering this in different sort of equipment that you are well known for, that we are well known for. The new range, we have the Atlan family of anesthesia devices, which we can talk more when you come to the exhibition stand, and we can provide you more materials on that. And of course, a lot of you are well familiar with the Fabius anesthesia family. Now, like I mentioned, hospital consumables and accessories are becoming very important in being able to deliver what those technologies are designed to offer. And in this range, you have varying anesthesia masks, including for pediatric patients. I've seen a lot of people who are impressed and fascinated by the scented anesthesia masks that we have for pediatric patients. So you can come over and see them and see what the technology is about. Soda line technology, which provides dust-free CO2 absorption, and a lot of other accessories that we have at the exhibition stand that you can join us to talk about. Of course, the intensive care environment and generally the workplace infrastructure that we offer. So for us, we are trying to look at ways that can work together with you to focus on improving acute care. So in the operating room and in the intensive care environment, we are looking for all opportunities to provide you with what will help you to deliver. Now, to round up my presentation, I will highlight one key strength of DREGA, and which is in the aspect of training and capacity building and development, and the clinical applications of the technologies that we offer to you, and also improving skills for different cadre of clinicians that work in the acute care space. So we have a new, because most times when you tell people DREGA, I think some of the feedback I got earlier in the morning was, oh, we've not seen DREGA in a long time. So we are re-entering the market from this year with a new office that we've set up for West Africa and East Africa. We started operations from the end of last year, and that means that you will see us a lot more intimate with you, being present with you in the operating room, in the intensive care environment, to be able to provide closeness and that intimacy with the solutions that you get from us. And these regional support offices for us are designed to provide application support, so that way, when you get the devices, you're able to use the devices as effectively as possible and get the best use of those devices. We had a training recently with clinicians, and some of the things that were being shown to them. For even people who have had some of those ventilators from the VAMED projects over 20 years ago, they realize that they're using maybe just 15 or 20% of the capacity of some of those technologies that they have with them. So how can we get you to be able to use a lot more? And then the service support, so that way after sales, we will have the right support to be able to ensure that those equipment that you have invested a lot of money in, that you're able to get the best value over ownership of those devices. And then in designing training, so training not just for products that you buy, but also in skills that are required within the acute care space, both for doctors, for nurses, for biomedical engineers, for the anesthesia technicians. We are designing training programs that will help to be able to improve care within those acute care areas. And these include online webinars that would be available, and also physical trainings that are also now going to be available as close and as proximal as possible to us. So I'll just take the time a bit to highlight some of the online resources, especially on the DREGA website, which you can easily access even from this second, right? Without necessarily being maybe like a workshop or a training event. On the website, you have a lot of tools and resources that would help you. So in designing some of those trainings that you want to use to help your clinical education development, on the website you will see an academic brochure where they will list all the different courses that are available for you to attend. We have a range of workshops across different areas: anesthesia, intensive care, neonatal care, patient monitoring that are available. And for some of these, I highlighted specifically the anesthesia workshops, where these are listed and you'll see them by date, and if they are online or they are in-person trainings that are available for you to access. So this is just highlighting some of the schedule that we have from this year, and you can go onto the website to be able to see some of those courses that are available. But not just the workshops, we also have a lot of resources that can help you. So we have a lot of case studies from different parts of the world on specific things that are related to anesthesia and intensive care. So these are things that you can access already on the site. Okay? And then we also have a lot of books. For those who are interested, I think we have some of the booklets already in PDF formats in USB sticks. So if you come over to the exhibition stand, you might be able to get some of those, which I have seen are very, very rich materials and resourceful for the residents and even advanced clinicians to use. And then we have videos which are webinars that you can also access, and videos that are related to product. So the other ones are not necessarily related to product, and then the ones that are also related to products. And then we have a range of clinical tools, also infographics and materials that provide easy information and clinical data for you to use. So these are a lot of different resources that we have available, and we would be happy to provide access to them already to you, which are open and public. And I've just highlighted the website, the link where you can use to access. And then if you want specific support with that, we're available at the exhibition stands to help you with that, especially related to medical education. Now, like I said, for us at Vega, we are there to provide you technology for life and support you for life, and to be life partners with you in the acute care environment. And currently, with our renewed strategy in West Africa, and specifically with focus in Nigeria, we have new partners that are able to support from the commercial to the after sales to the technical to the training components, and we will be executing this with Genos Group and also with Uni Medical. So if you already have a relationship with them, then these are avenues that we would use and platforms to expand those relationships and add value to you. And when you're looking for the accessories that I've talked about, which we also have on exhibition at the stand, these are your partners or our partners that you can go to. Thank you very much for your time.
Thank you so much. I'll call on Dr. Fatima Tahir to read out the citation of the next presenter. Thank you.
I'm honored to read the citation of our noble teacher, father, and senior colleague, in person of Dr. Arinze Walson, MBBS, Fellow Medical College of Anesthesiologists, is a chief consultant anesthesiologist and former head of Department of Anesthesia at National Orthopedic Hospital, Enugu. He is an alumnus of the University of Jos, having received his degree in medicine and surgery from the university in 1989. He is passionate about physician wellness and has authored several peer-reviewed articles in this field, among dozens of other scholarly publications. Dr. Walson is a live member of the National Society of Anesthetists and currently serves as Southeast Zonal Airway Lead for the Society of Specialists in Airway Management, SSAM. He is happily married to Mrs. Roslyn Nkechi Wonsu, FCA. With a rousing applause, I welcome Dr. Arinze Wonsu to present his lecture. Thank you.
Incidents and factors associated with failed spinal anesthesia among adult patients undergoing surgery below the umbilicus, below the level of the umbilicus on 4 tertiary hospitals in Nigeria, to be presented by Dr. Balla. Thank you very much.
Associated with failed spinal anesthesia. I'm going over these highlights. Introduction, methodology, result, conclusion, and reference. You know, spinal anesthesia is becoming the technique of choice among anesthetists, because some of the advantages we know it provides both anesthesia and analgesia. You know, it overcome all the problems associated with airway, decreased rates of toxicity, and we know it is the commonest technique that is performed in usually low-resource settings. And it is very easy to teach and also to institute. But despite that, you know, it can fail. There is no consensus definition about failure. The failure is either complete or partial. Complete if we have sensory or motor blockade. Partial if the intensity is insufficient or the quality for particular sort. This study, I must tell you, is still ongoing. It's an ongoing study. We are just presenting preliminary results. The objective of the study is to determine the incident and factors associated with first spinal in adult patients. These are the centers that participated in the study. We have Asokoro, Azare, Bauchi, and Gombe. It's a multi-center study. We started in February 2023, and so far we have conducted the study on about 1,500 ASA 1 to 3 patients who have met the criteria for subarachnoid block. I know in addition to the indications and contraindications we know, we added those with history of difficult spinal or failed spinal. We excluded them from the study. And we use 0.5% of again, and we allow for orthopedic surgeries for use of 25 microgram of fentanyl. To calculate our sample size, we use a study by Hamid et al. That got 16.1%, and we got a sample size of 473, minimum sample size. The data we collected data on patient characteristics, anesthesia related, and procedure. And this data we collected, we coded them and entered into Microsoft Office Excel program and transferred to SPSS version 20. The quantitative data like age, body mass index, we expressed them as mean and standard deviation and presented them as graph. While for the qualitative data, we used the appropriate descriptive statistics, mostly percentages, to present our result. And for comparison between the qualitative data, we use chi-square test. And p-value less than 0.05, we consider this significant. It's just what I was trying to explain because of the time. These are our site investigators from all the centers. So our study flowchart, so far, Asokoro has the highest number recruited, and it has excluded no patient. We have the highest exclusion from Azari, mostly from use of wrong drugs. Then for now, the total sample size we are on now is 1,494. And these are our results. The mean age so far is 30 plus or minus 24. The sex, the ratio of male to female, the female was 47% and male 43%. The p-value was greater than 0.05, so it was not statistically significant. Body mass index was 29 plus or minus 6. The ASA, no statistical significance between the three classification of ASA, 1, 2, and 3. So far, the overall incidence we got of first spinal is 13.9%. Out of the 1,494, we had 207 failed spinal. So we compared first spinal based on the body mass index. Those that have their BMI less than 30, the failure rate was at 7, while those with BMI greater than 30, the failure rate was 63. The p-value was less than 0.05, so it's statistically significant. BMI, high BMI, and first spinal. For elective surgery, 42% of these surgeries were elective, and 58 elective, 42 emergency. No statistics determining the significance between them. And even based on the outcome, there is not any significant difference between the two groups. emergency, and we look at the experience of the anesthetist. We consider 2 years of anesthesia practice as experience. On the total patient, consultant administered anesthesia to about 600 patients, the resident about 650, nurse anesthetist 280 that they presented. So by CADA, the failed spinal, we look, the incidence of failed spinal among nurse anesthetists was 49%, while among the resident doctors was 43%. There was only 8% failed spinal in the dose administered by the consultant. The p-value here too is less than 0.05. So there is also statistically significant difference when the CADA of those. Then the level of lumbar puncture. Those that administered at the level of L2, L3 was 20%.
Recording stopped.
L3, L4, 19%, L4, L5, 61%.
Recording in progress.
Based on the patient's position in failed spinal, the conduct of subarachnoid based on patient position. We look at out of 179, 127 was failed in those that were given in lateral position, but only about 80 out of 1,314 among those that were given in sitting position. So the failure rate was higher among those that had the spinal at the lateral position. So all the participating centers, we use the same needle pinky type, that type 25, 26, 27, the ones that the study permitted. So far, some of the centers are reporting that this is something I want to discuss from this NSA, the scientific conference. The centers are reporting that the drug is not potent for those that have failed spinal or the potency is reduced. But the proforma we designed for this study has no capacity to detect whether the device is potent or not potent.
Battery.
So far, we have observed that obesity, the experience of the anesthetist, the level of lumbar puncture, and the patient's position are associated with failed spinal anesthesia.
Thank you, Dr. Lala, for this presentation. I would like to call on the next speaker. He's going to talk to us about the use of GOMBE elastic bougie to facilitate nasal intubation in a patient with bilateral TMJ ankylosis, a case report by Dr. Ibrahim Salim Abdullahi.
Thank you, Chairman. So, the title has been mentioned. Airway management in patients with coronavirus joint ankylosis is challenging to the anesthetists, especially in the resource-poor settings where aortic intubation equipment is not available or the skills are not available on board. No skills, no equipment. So therefore, blind nasal intubation remains the only available non-surgical option for such categories of patients. The bougie is a useful airway adjunct, a simple and reusable tool associated with increased first-pass success in obtaining a definitive endotracheal airway. It provides visual and tactile confirmation. So this abstract presents an incidental finding of bilateral temporomandibular joint ankylosis in a 28-year-old woman who was booked for emergency abdominal procedure. The aim is to highlight the challenge of her airway management between the ideal technique and what was available. She's a 27-year-old para 4 alive. Last time was 13 days ago. Presented with fever, foul vaginal discharge, easy fatigability. She was initially managed for peripheral sepsis and anemia confirmed by symptoms resolved with antibiotics and then blood transfusion. While on admission, she developed lower abdominal pain associated with vomiting. There was right iliac fossa tenderness and then a positive psoas sign. Abdominal scan revealed an ill-defined hyperechoic connection in the right iliac fossa, querying nature, and then was querying abscess, psoas abscess to rule out appendiceal mass. General surgeon invited, they reviewed, and they made an assessment of pelvic abscess to rule out ruptured retrocecal appendix. So patient was booked for emergency X-lab. The pre-anesthesia finding were that we was found to have spent 4 weeks on admission. He has lower abdominal pain. There was no abdominal distension or fever. She has been on nil powers for more than 24 hours on fluid maintenance. She had 5 pints of blood transfused since admission. There was no any non-comorbidity or history of allergy. There was no previous exposure to anesthetics. Then another finding was that this patient has serious financial constraint. Her bills were put by contribution made by the managing team and medical students. She was also found to have moderate dehydration, which was optimized before the surgery, and IV access was in situ. That's her vital signs. So the incidental finding of severely restricted mouth opening, missing upper incisors, and then dental anarchy. The interincisor gap was less than 2 centimeters, but however has normal temporomandibular distance, and then there was no limitation in neck movement. Available results, except for hypokalemia 2.8, also was met on correction. PCD was 29%. So the plan was to get her consent for the procedure to group cross-match 2 pints of blood, and then the anesthesia technique, general anesthesia with endotracheal intubation. So the airway management options, which was the challenge, the first option was awake fiber optic intubation, which is the ideal, however, was not available. We don't have the equipment. Then our next option is blind nasal intubation, which we all know is associated with failure rate. And then the last option, which is tracheostomy. Locally we have an ENT surgeon, but then it was a difficult task having to explain to the patient with an abdominal pathology for abdominal surgery that we are going to create a hole in the anterior neck, separate from the abdominal incision that she will have. So, but then that was the one limited option within what was available. So we plan to attempt blind nasal intubation with the ENT surgeon on standby. So where it fails, then the tracheostomy can be cited. This is the picture of the woman pre-op. You can see this is the best mouth opening that can be achieved. The intra-op, the safety checks were done. She had pre-medication with glycopyrrolate and pre-oxygenation done. She was induced with incremental dosing of anatane in oxygen until deep plane of anesthesia was reached. The first 2 attempts of blind nasal intubation failed. However, we undertook a third and last successful attempt, which was achieved with a bougie, which elicited cough and provided tactile confirmation of the trachea. So a 6.5 millimeter ETT was eroded into the trachea, and then the procedure continues. Tracheal intubation was further confirmed by 5 points of auscultation. Balanced anesthesia technique was maintained there, a closed circuit isoflurane in oxygen. Standard monitoring was employed throughout the procedure, which was uneventful. At the end of the surgery, neuromuscular block was reversed and then extubated fully away. This is the patient intraoperatively, and this is the mouth opening even under anesthesia with muscle relaxation. So bilateral TMJ ankylosing is a rare condition which is characterized by limited mouth opening due to bony fusion of the jaw joint. Administration of anesthesia and airway management in such patients ideally requires the availability of flexible fiber optic bronchoscope and trained personnel who can use the equipment. However, many facilities, especially in the developing countries, are lacking either the necessary skills or the equipment or both. Retrograde intubation, tracheostomy, and blind nasal intubation are possible options for airway management of these patients. The bone elastic bridge to facilitate blind nasal intubation can be utilized for cases of bilateral TMJ ankylosis to improve the success of conventional blind nasal intubation, especially where intubation, fiber optic intubation equipment is not available or the skill is lacking. Thank you.
Sevoflurane versus halothane for endotracheal intubation among under 5 children scheduled for elective surgery by Dr. Gideon A.
Thank you very much. All protocols duly observed. So I'll be presenting under the following topic. Outline. Introduction of inhalational anesthetic agent is one of the greatest landmarks in development of anesthesia. Inhalational induction of anesthesia is practiced very frequently in pediatric patients because of difficult venous access and the fear of needle placement in children despite the use of topical anesthetics. This gives inhalational induction of anesthesia in children upper and over intravenous. Tracheal intubation may be facilitated using succinate choline, non-depolarizing neuromuscular blocking agent, or using propofol with alphentanil. Though succinate choline is good for provide good intubation condition, but when used to facilitate intubation, it may produce or it has a myriad of side effects, which include hypersensitivity, cardiac arrhythmias, hypotension, hyperkalemia, muscle fasciculation with resultant muscle pain, and so on. Hence, inhalation induction of anesthesia without the use of neuromuscular blocking agents has gained more ground in clinical use in children. Since the discovery of short-acting opioid drugs, tracheal intubation without the use of neuromuscular blocking agent has been very successful, especially when propofol is used with opiates. We know that opiate helps in to blunt the pressure response to laryngoscopy. Halothane has been the main drug used for several years in children, which has also produced a good intubating condition. But we know that halothane has some side effects like myocardial depression, cardiac arrhythmia, particularly when used in high mean alveolar concentration. In addition, halothane undergoes significant metabolism, which may cause a rare or serious complication of hepatitis. So, in our centers, I think that is 2018 when this study was done, sevoflurane was introduced. And we know that sevoflurane has a very high cost, and most of our patients are indigent patients who pay out of their pocket. But we saw that if this sevoflurane produces a better option compared to halothane, this high cost can be justified. So the aim is that to determine the ease of endotracheal intubation and safety between the use of sevoflurane and halothane for induction of anesthesia in under 5 patients scheduled for elective surgery. Our material methods is a randomized blind comparison study using pediatric patients between ages of 1 and 5 years scheduled for elective surgery from May 2018 to December 2019. Ethical approval was obtained from Harvard Ethical Committee. Approval to commence study was given by the National Postgraduate Medical College of Nigeria, and informed consent was obtained from the parents. A statistical analysis was performed in statistical package for social science, version 21, and the p-value less than 0.05 was considered statistically significant. Results. These are results. This is the demographic and clinical characteristics, the age, weight, and sex comparative between those that are given sevoflurane and halothane. This is the heart rate. There is no significant difference between those that were induced with sevoflurane and halothane, even though we see that there is a slight difference in the heart rate, but it's not significant. significantly as significant. It's not significant. Mean arterial blood pressure changes. Before pre-induction, we saw that there's no significant difference. But after induction, 1 minute, 3 minutes, and 5 minutes after intubation, there is significant difference between the mean arterial pressure with halogen showing myocardial depression. Peripheral oxygen saturation, there's no difference between the two. And this complication, one, we saw that laryngeal spasm 3 that were induced with halogen has laryngeal spasm, one has bronchospasm, 7 of them had hypotension because we said halogen causes myocardial depression, and that's why we have hypotension with 2 having bradycardia. So the total of complication in sevoflurane is 3, and that of halogen is 16, and this is statistically significant. This is the intubating condition. Those that have excellent intubating condition, that's blue color is sevoflurane, and the green is halogen. You can see excellent. That of sevoflurane is small, and this is good. This is acceptable. So the mean induction time for halogen and sevoflurane was 4.5 and 4.7 respectively. The induction time are longer than the finding of Kandraka et al., which reported a mean induction time of 71 seconds and sevoflurane 138 seconds for halogen. And this is because they use nitrous oxide. And we know that nitrous oxide has a second gas effect, reducing the induction time. Also, Basca and colleagues also they found out a lower induction time, and this is the fact that also they use nitrous oxide. And secondly, the maximum concentration in volume percent for sevoflurane is 8%, while that of halogen was 5. When compared to our study, it was 7 and 3 respectively. So this study also found that sevoflurane provided better intubating condition compared with halogen. In the sevoflurane group, 51.7 had excellent intubation condition, while the halogen is only 39.5 had excellent intubating condition. Overall, 92% of the children in the sevoflurane group had acceptable intubating condition compared to 81.4% in the halogen group. This is similar to the finding in the study of Blair and colleagues, where acceptable intubation was around 97 in the sevoflurane group.
Wrap up, please.
Okay. In conclusion, compared to halogen, sevoflurane provided better intubating condition and hemodynamic stability. Sevoflurane is better and safer to use as an induction agent for endotracheal intubation in under 5 children compared to halogen. So thank you very much, and these are my questions.
Let's finish within time. Then hand over the mic to the rapporteur to give us the summary of the presentations. Thank you.
Thank you very much, Dr. Nko. So at the end of I want to summarize the second scientific session. The first speaker was presented the incidents and factors associated with failed spinal anesthesia. He talked about spinal anesthesia being a technique of choice for low abdominal surgeries, simple to do, simple to teach, and it has a rapid onset of sensory blockade. He also talked about, he defined failed spinal, saying it's about when there's a partial block within 15 to 20 minutes, or when you require supplementation or extra analgesia. The results, the incidence was about 13 to 19%. He compared BMI of patients less than 30 kilogram per meter squared. So patients with high BMI are treated with failed spinal. He also compared emergency and elective procedures to failed spinal, concluding that more emergencies are at risk of failed spinal anesthesia
Then the experience of the anesthetist, it was shown that less consultants had the consultants had less complications, while the nurse anesthetist had more fluid spinal anesthesia. He also talked about the level of lumbar puncture and then the positioning of the patient. Patients that are positioned in the lateral, patients in lateral position have more incidence of fluid spinal, and then he's worried about the potency of the agents. That's for the first presentation. Then the second presentation was a case presentation of a 27-year-old woman that was booked for emergency exploratory laparotomy. She had a pelvic mass, pelvic abscess, and she's been on admission for 4 weeks because of financial constraints. So during preoperative review, she was noticed to have difficult airway. She couldn't open her mouth. So there were preparations for surgery. Because they didn't have a fiber optic to use, they couldn't do fiber optic for her. They went for blind nasal intubation, though the ENT surgeon was standby. Patient was induced with halogen and then had 2 failed intubations, and then the third attempt, the blind nasal intubation with the bougie was successful, and then entracheal tube was re-rolled. Surgery was done and patient recovered. So the conclusion was that gum elastic bougie for blind nasal intubation can be used when fiber optic is not available and the skill is not there. Then the last presentation was on inhalational induction, comparing the effects of sevoflurane and halothane in less than 5 years, 1 to 5 years of children. So it was an elective surgery, and it talked about the different intubating conditions and the complications associated with inducing children with the different inhalational agents. The results, they've done over 1,000 children, and the results show that sevoflurane had less complications compared to halothane. Halothane had complications like bradycardia, hypotension, laryngeal spasm, and it had a longer time for induction. In conclusion, for the presentation, sevoflurane was seen as a better and safer inhalational agent to use in patients, the under 5 children. Thank you.
Thank you for the good summary. With this, we come to the end of the second scientific session. Thank you very much for listening.
So starting with our dear Associate Professor of Neuropsychiatry, I would like to ask you, sir, just give us a summary of what are the factors that actually draw people into getting involved in substance use to the point where it becomes a disorder. Thank you.
Thank you very much. Number one, substance use is a neurobehavioral disorder. What that means is that when there is a dysregulation of the neural cycles within the brain, then you will have problems of substance use. Secondly, there is absolutely no clear etiological pathway to the development of substance disorders. However, there are certain factors that have been associated with it. Number one, there are social factors, abandonment, living alone, having an unfaithful partner, not having someone close to confide in, having a very troubling, time growing up, childhood stages, sexual abuse as a child, emotional abuse, physical abuse by your parents, divorce of your parents. These are factors that tend to predict development of substance disorders. There are other factors. Your inability to control your emotions, your inability to control, circumstances around you. All these can come together and make you vulnerable to the development of substance use disorders. Let's go back a bit to what substance use disorders are. We said they are develop behavioral problems. What are those functions that are affected? Your inhibitions, your memory, cognition, your ability to respond positively to stress. Once those pathways have been disorganized, you will find other ways to try to cope with that dysfunction. And one very easy way that people have found to cope with this disruption in the neural circuits in the brain is to use substances, alcohol, nicotine, smoke. Just imagine in this hall now that this light goes off. As soon as darkness descends in this hall and a light comes up, just one bulb around there, that light will tend to stimulate our sensory structures in the brain. It's the same thing with substance use. And so once there is a pleasure center, which the nucleus accumbens, all of that in the brain. So once the substance is that light that I talked about, once that substance, it could be alcohol, it could be cigarettes, it could be cannabis, it could be opiates, whatever it is. And for those of you who are anesthetists, the commonest thing is what you use in the theater, isn't it? It's availability. Availability is also a factor. Once that substance is available to you, it stimulates your pleasure center. And you want to do it again. You want to do it tomorrow, and again, until you lose control. Thank you.
Thank you very much for this snapshot into the safe factors and then also trying to trace the neural pathways. Without wasting time, actually, I know you told me that you can't deal with this subject in a short time and beyond.
Actually, I confess to her that I traveled all the way to Jos and I cannot speak for just 3 minutes.
But you still travel. Thank you so much. We understand that. And I'm sure the audience understands too. But we have to kind of control the time now. So, Professor Lomu, I know you have been having special interest in this topical issue, and I would just like to ask you to focus on the anesthesiologist part in particular. He has tried to mention some things, but I want you to now please kind of put to us in order of importance, gravity, what are the special agents? I know you have taken us through a fantastic lecture, but please remind us again now, what are the ones that anesthesiologists tend to favor more, and then the bigger medical team in order. Thank you very much.
So you're asking about the medications?
Yes.
Okay. So, thank you, Madam President. Thank you, co-panelists. So my talk, the fentanyl is by far the most commonly abused. Okay. Once you get into a system of reward, right, the nucleus accumbens as a reward pleasure center. Once it gets disorganized and activated, you've lost control. So you just want that reward, no matter how horrific it is. And as time goes on, you just keep taking more and more to get the same level of pleasure until you overdose. We had a resident in my department. She was abusing, but again, these people are very smart people. Okay, let's just be honest. We're doctors, we're smart, right? So we can play tricks, we can hide this thing, and nobody knows about it until, it becomes a little bit, getting too late. So she was acting weird. She was a final year resident in anesthesia. She was doing a neuro case. She was acting weird, and the surgeon knows her from before. He knows her well. She said, this is not on. It's not normal for this girl. So he went and reported to the anesthesiologist in chief for that day. And sure enough, she was taking fentanyl. So the final year was able to take her out of the OR, sent her to rehab. She did well, was able to return. I didn't cover the topic of relapse and re-entry, some other areas. How do you get them back into anesthesia? What are the criteria that we have to follow? And sometimes they have to change specialty. Sometimes if it's so bad and they keep relapsing, you have to get them out of anesthesia to a different specialty. So opiates is number one. Alcohol was another one. We had, it is a problem. We had a resident die about 5 years ago, again in my department. That was so crazy. He was using opiate and then fentanyl. He went and got a girlfriend who is a dentist who was using cocaine. So it was cocaine, fentanyl, between both of them. And then one day he OD'd on fentanyl and he died. It's one of my residents about 3 years ago, about 4 or 5 years ago. So that's why, if you read, there's a JAMA article you read about, it's called A Death in the Family. Google JAMA and just say, look for a death in the family. So that's about my resident from 5 years ago. So this is a problem. So narcotics, benzodiazepines, alcohol, and now, like I told you during my talk, propofol is becoming a big problem. All right, because now it's not controlled. In America, we account for every narcotic. So if I pull 100 mice of fentanyl in a vial, and I do pediatric stuff because it will be 10 or 15 mice, I have to waste the remaining 90 mice with a witness, with a nurse or another thing. It has to be wasted. We have to account for every drop of controlled substance that you use. And just like, oh yeah, I use 10. I don't know what happened to the other 90. No, you're going to pee in a cup. That's what we call it. In America, I would say pee in a cup. That's a code word for you're going to get a drug test. So that's it. So if you keep doing that, they're tracking you. You're not giving an account for your narcotics. You're going to go to the headmaster's office, i.e. head of department, and then they're going to take you to the clinic to pee in a cup and check you. So these are the things. So across the problem. Another problem is if you tell them, if you need to work on somebody who's already been caught and tell them to abstain, they must also abstain from alcohol. So you can't just say, okay, I won't use narcotics. The abstinence includes everything, even if you're caught on fentanyl, but you must abstain from alcohol and other similar drugs, because that's going to get you to relapse and just set you back. So yeah, in terms of whether narcotics, is it available to us? Benzos, propofol is not becoming a big problem. Some hospitals not control it, but the hospitals not controlled, so you can take it. So yes, and then cannabis, of course. In America, they're so crazy. They don't think cannabis is a problem. It is a problem. So yes, so we want to be aware, and like I said, if you see something, say something. Okay? If you suspect, don't accuse them. Don't go to them. Accuse them. Just talk to your upper level. Talk to your HOD or your director. Let them go through the due process and give everybody a fair chance. But it's our duty as physicians to take care of our own and prevent unnecessary death. Thank you, Madam President.
Okay, thank you very much, Professor Long, for that enlightenment you have given us. Thank you so very much. I like it, Hamad. We are so grateful to you for your passion and for honoring our invitation. On this note, I would just like to conclude that what we have gathered here, even though it's not an exhaustive session, is that one, substance use disorder arises from various problems relating to psychosocial disruption and imbalances or problems in the workplace, or instabilities in your relationships, and usually there is a tendency for people to want to indulge opioids more, and then alcohol. Of course, in our environment here, we should not forget pentazocine, right, which is very common. Maybe they don't readily get fentanyl, pentazocine and tramadol is easily gotten from them. And then, we need to understand the fact that they have to go back to the grassroots, and help them in community health-wise and bring them up in the proper way. And then our cleric has told us that we have to begin to also ensure that homes children are properly brought up from their early days, and with that we can have some hope that we'll have children who will be stable and grow up also into stable adults who can manage their challenges in the proper way. So on that note, I want to thank every one of you, and I will hand over to Dr. Jika, who is the HOD of the Department of Anesthesia of GOMBE Teaching Hospital, and he's also a member of the NSA, the secretary. Thank you very much.
Good evening to you all. Permit me to stand on the already existing protocol. It's such an honor to be part of this great gathering. So, on behalf of the local organizing committee of NSA GOMBE 2023, I would like to extend our heartfelt gratitude to all of you for finding time to make this event a success. Madam President, you and your EXCO team, we can't say enough thank you to you for all what you have been doing. For the whole day since the state group is going to host this event, they have not abandoned us. They have been with us in physical, in virtual, and their support is really showing now, so thank you, ma'am. For our guest speakers, who are our teachers, our mentors, they are not tired of continuing spreading the knowledge, both the physical knowledge and the practical knowledge and the theoretical knowledge. Thank you, sirs. We are very grateful for that. For all the participants who have presented one or two abstracts to enable us get the latest of what is actually going on in the anesthesia-related topics, we say a big thank you to you all. For everybody that make this event possible and a success, whether present or is not here, we extend our heartfelt appreciation to him. We wish everyone a peaceful stay in GOMBE from now to the end of the program, which will continue tomorrow by the grace of Almighty God. So with that, I say thank you all. We really appreciate it.